I think it was very interesting to me because I'm not a person, a psychiatrist who works with families. I'm not trained as a family therapist in any way. But I think this research is greatly interesting, really, for what it shows, and terribly important because the work with families is obviously of the greatest importance, especially in this field. Where do I point this, Rita?
At the cupboard.
Oh, at the cupboards. Right. That's fantastic. That's great. Okay, point at the cupboard. Okay. Now, as you see on that slide, studies show that the families and carers of someone with BPD experience a significant sense of burden, objective and subjective. Now, when I use that word burden, there's no mention or suggestion of blame in that. It is about the distress that the families feel, the feeling of needing to be there for their loved one. It's not that in any way the patient or the person with BPD is blamed by using that word. But that is the word that is in all the research, hence it's the word I used, because it really came through again and again. Now, the sense of burden in families of someone with BPD has been reported as greater than in any other psychiatric illness. Now, this is a huge thing, greater than severe schizophrenia, severe bipolar disorder, greater than associated with any other severe mental illness. So, very significant findings. And the studies have shown the feelings listed there: elevated stress levels, hopelessness, powerlessness, feelings of diminished social support, increasing social isolation, of course, stigma, grief, guilt and distress. So a huge range of very difficult feelings. I thought I would just define what is objective burden and what is subjective burden, because these are the terms used in all the research. Objective burden refers to the observable effects of caregiving for a family, the sort of demands of time, demands of money, limitations on activities and so on. Subjective burden, on the other hand, refers to the feelings and attitudes that family members experience toward their family member. A sense of stigma that that person is experiencing, no doubt in the world and troubled by. A sense of stigma that the family may experience, of course. Worry, depression, anxiety, guilt. Guilt because they so often think, what have I done? What have I done to cause this? Is it something I did or didn't do? And we all know here that sometimes things have happened, but those family members who don't often come for help, in my experience. Okay, shame and hopelessness are among the feelings. Now, what I want to do in this presentation is outline the history of work that's been done so far, the research on work, and what the review shows, and consider, importantly, where to go from here. Now, this has been a very unedifying, disappointing whole area, because it really wasn't until the early 2000s that even work with families of people with BPD began. There was just nothing in the literature until then. And family members of carers felt so often ignored, and not just ignored, but in a way mistreated, just ignored and badly treated by clinicians in the field. And things still haven't changed enough, but they have begun to change. And I found the following, I think, were pivotal to the change, but there are other things as well. The wonderful Gunderson, who, as you all know, was the first to actually define what is borderline personality disorder and to distinguish it with Grinker, a colleague, from schizophrenia. Because first of all, it was regarded as, as you know, a form of form first, if you like, of schizophrenia. And it's not that, as we all know. It can be comorbid with schizophrenia, we know that too, but it is not schizophrenia. Okay? So he published a chapter in 2002 on multifamily psychoeducational treatment. Now, there's been no outcome research on that treatment. And it's interesting that it was psychoeducational treatment, no other form of treatment, because there's one study in particular, which I haven't gone into in any depth here, that shows that psychoeducation for families actually can increase their sense of burden. And I wonder if it's that they find out things from psychoed that they didn't know about borderline personality. I don't know what those things might have been or be, but they found their level of burden increased. And in my view, it's only with the later work where families are helped and given assistance to know how to validate emotional states, know how to give support to their family member, that the interventions for families have been, in fact, helpful. So psychoed, I think, depends how it's done. And it's always part of all these interventions, and we'll see later when I go through the phases of or the process of the interventions that have been effective. It's always an initial part, but it's only an initial part, and things progress after that. Family connections is probably one of the most well-known of all the aspects of family work, and it's a training manual for that. It's a DBT based framework, and has some very good outcome studies. Hoffman and Frizzetti, again, you notice Frizzetti's always in many of these endeavours, published data on its effectiveness with relatives, found to be effective, and for the effects to be reasonably lasting. Unfortunately, none of the studies, except maybe one by Flynn, which I notice a reprint of somewhere here, a 2017 study, which did follow up the intervention for between 12 and 19 months, and they showed that their positive effects had been maintained. So that was a very significant and new study, because no one else, including Bateman and Fonagy, then in a minute, had done such a long follow-up study. And that's one of the problems. There isn't sufficient research. How much do these changes, for example, that last one, Pierce, someone here, was Andrew Channon, is one of the authors, so it has to be done here. Very brief, 3-session psychoed group intervention for family and friends of youth with BPD. But they only measured the outcome at the end of the intervention. Now, in my view, that's just not good enough, because of course they said they learnt a lot about, and that was what it was supposed to do, so you'd hope, goodness, they'd learnt a lot. But we have no, and there was some decrease. I can't remember the exact findings, but I remember thinking, look, 3 psychoed groups, yep, that's good, it's great they did it, but why didn't they try and follow it up to see if any benefit, and there were benefits, were lasting? And I think that's an important take-home message for the research. Now, this is the excellent study. Flynn, Kells and others compared a family connections program, you know, the Hoffman and Frizzetti program, DBT program, with optimised treatment as usual for families of someone with BPD. And they did conduct the long-term follow-up. And they found very significant benefit from the family connections program. The optimised treatment as usual for families, it had,
bang the door.
They had, what they found in the optimised treatment as usual was that improvements were in the direction of the family connections, but they didn't reach significance, whereas the family connections did reach significance, and it was very well maintained between 12 and 19 months, I think, later. So that was very significant. And Bateman and Fonagy, I'll give more detail about their work later, this year published the first randomised controlled trial. Now the randomised controlled trials are trials where you compare and thought to be effective treatment with another thought to be effective treatment. That's what a randomised controlled. See, optimal treatment as usual is that treatment as usual, as we know, isn't usually very effective. As indeed in this case it was not for the families at least. Now, and unfortunately, while it was fantastic that they did compare their family-based intervention program with another effective, the same in fact. What they did was they took one cohort of families here and they measured all that, and then 3 weeks later they took another cohort. They'd had a group on the waiting list, and the waiting list program group, they were measured. They were the comparison group. But of course that meant that the follow-up was 3 weeks. Anyway, I'm sure that they're brilliant, those two, so they'll do more. And clearly they had some very positive findings of the program and the 3-week follow-up. The improvements were maintained. It's not long enough, it's not good enough, but it was the best they could do, and they, like all of us, I guess, have funding problems, and that was what they were able to do at that point. So things are definitely moving in the right direction, but we're not there yet. I'm always fascinated by what triggers the improvements that have occurred. Why did these occur? Why didn't it stay as bad as it had been? And I have a number of thoughts. One is that Gullison, in the 1990s, way back then, said that families suffer the same difficult emotions as clinicians when the person with BPD threatens self-harm or suicide or is uncontrollably angry. As you know, or many of you know, clinicians often feel very intense feelings while treating patients with BPD. Distress, concern, worry, anxiety, guilt if they think they've all the stuff, and sometimes anger. We all know that. But did his statement that families suffer the same emotions as clinicians, did that trigger awareness in clinicians? Oh, hang on, these families probably need some help. Because by then, clinicians were encouraged to get supervision, you know, with patients with BPD. People recognise that the intense emotions that we feel as clinicians are important to understand what they tell us about our patient, how they improve our understanding of what's going on in our patients' mind, and that too, very, very importantly. But I think maybe clinicians thought, oh, hang on, these families might need some help. And then there's the negative expressed emotion work. You remember that with, they found out that negative expressed emotion, which is hostility or criticism of people with schizophrenia, this was Falloon and others in way back, that criticism and expressed hostility, expressed criticism of those patients actually had a very adverse effect on relapse. It shortened the time to relapse, it made relapse much more likely to happen, and in fact, fascinating finding, it was as adverse, if that's the right word, at triggering relapse as was the patient stopping the medication for schizophrenia. So we're talking about a very, very strong impact. Okay? What did high expressed emotion do in borderline personality disorder? Well, that's only been much more recently studied, but fascinatingly, high negative expressed emotion did not worsen the effect, the impact on people with BPD. And what the researchers think, or have surmised, seems to me to make sense, was that people with BPD want their families to be involved. And even if there's negativity, and even if there's hostility, at least they're there, at least they're interested, at least they're engaged. And particularly if any negative emotions or criticism were accompanied by validation, they could have a very useful effect in the family interaction. Because it meant, I think, it meant to the person with BPD that family members cared. They cared enough to. Does everyone think that makes any sense?
That makes sense.
That's the theory. It's a very important idea. So it had a reverse effect in BPD. And did growing awareness of genetics and inborn temperament and how terribly important they can be in the etiology of borderline personality disorder, did knowledge of that assist the change? I suspect it did. And Valerie Paul's book was published in 2010, but I think that has been a very important factor because it's a very it's American and sometimes the writing's a bit irritating, I find. But it's excellent. It talks in a very empathic way about the difficulties for families, difficulties for the person with BPD, and how to try and address them. She's terrific. I think she may have had I don't know this, probably shouldn't say, but could remain in this room. I do wonder if she had a family member with BPD and she'd probably had to struggle to find these things out for herself by hook or by crook because there was not much around. So I don't know that for sure, but I do wonder. Now, and Frizzetti, I think, again, Alan Frizzetti, who's a DBT expert, he postulated that way back, people with BPD are unable to communicate their internal experiences effectively or accurately, and that increases the likelihood of invalidating responses. And invalidation in turn leads to increased distress, emotional arousal, and dysregulation. And then reciprocal cycles of blaming can get established in a family. When family invalidates the patient, the person with BPD is very upset, they're probably aroused, angry, then the family, and so on and so on. You can see this, can't you? And he showed that if you can intervene in that vicious cycle with helping family members validate what's going on for the person, in increasing the family members' emotional control and capacity, you can help stop that downward spiral. And I think that was a terribly important piece of knowledge, piece of understanding, because it's not blaming anyone, it's talking about a vicious cycle that we can all get into. You can imagine, my husband might fight, and it doesn't go well until one of us, usually me, of course, breaks it somehow. Okay. Now, Fossati and Sommer, I don't know who Sommer, I've never heard of that one before. But this is a recent paper, and I wondered what you all thought of this. They suggest that family interventions may be particularly useful when the severity of suicidality, self-harm, drug abuse and so on in the person with BPD are causing dysfunctional family reactions which could interfere with the treatment of the family member. Also, could be particularly useful when the level of burden on the family is causing that reciprocal blaming that we talked about before, when the person with BPD and their family come to conflict, each blaming the other for what's happening. When there's a high level of conflict among family members, particularly when that might interfere with the person's treatment, and interpersonal dysfunction among relatives of the person, and a marked conflict between a family member and the person. Now, I think that's most interesting because there was one study, and I can't remember which it was now, but it showed that when people, families who weren't highly anxious about the person with BPD came into a family intervention program, they came along, they were invited, and off they came, their anxiety actually increased. And I wonder, again, whether that was about the psychoeducation part of it, and maybe when they got into the other parts of the program, which I'll show you in a minute, programs, they thought, oh, this is what could happen. I just wonder if it frightened them at some level. So I think this is a very important, potentially very important piece of knowledge, that perhaps it's when things are not working well, that's the time to intervene with a family program. Okay. Now, the emerging evidence shows that family members can be trained to provide very effective programs for other families and carers with a member with BPD. No one knows yet if the family member training by family members, is better than, or more effective or more helpful than training by clinicians, because it could well be, you know, they're trained in how to give the program, and after all, they've been there, you know, they've been there. They know from experience just what it's like, and they may be able to convey a deeper understanding, perhaps, than clinicians. But we don't know. We need more research about that. But I do notice that the family connections training is usually done by family members, trained family members, and that Bateman and Fonagy used trained family members to co-participate in that. I think they were the only trainers, but they were part of the training. And they contributed to writing the manual, the MBT manual for it as well. So a significant input. Now, Fonagy and Bateman interviewed a large number of families before they developed their program and asked them what would they like, what sort of interventions, how long, what would they like to know, and that family members, without exception, said they wanted brief, and they ended up, I think, with 5 or 6 weeks, I can't think of that. But not long, not too long. It all felt too much, obviously, when it went on for months on end, as some of them had in the past. So let's look at some more details. That was the first program developed by Hoffman and Frizzetti, DBT Family Skills Training. And that was a multi-family intervention for people with BPD and their families. Note, the person with BPD and the families were there in that intervention. They aimed to help family members understand the theory and the language and the skills the person was learning in treatment. Fundamentally, they wanted the family to be on board with the person's treatment, so that the family had some idea of what was happening and could support their family member during the process. Now, the effectiveness was not assessed at that, but I thought it was significant that they then developed the Family Connections program, followed by the Family Connections, Just Family Connections. And the difference between Family Connections program and Family Connections was that Family Connections was led by family members. So there's a process here. First, the person with BPD is in with the family. Second, clinicians lead the program. Finally, and it's very much, I think, the same program, is led by family members. And I think they wouldn't have done that unless they thought family members could be more effective. But they haven't researched it. They haven't compared trainings done by clinicians and trainings done by family members. At least if they have, I couldn't find the studies. Family Connections, here it is in a bit of detail. It's 12 weeks, a bit longer than Bateman and Fonagy's patients wanted, parents wanted, families wanted. It's manualised, highly manualised, and it's for families, not for the person with BPD. It's run by professional staff, it's DBT based, and these are the components. Current information and research on BPD, so you might say that's the psycho-ed bit. Then training in coping skills, then family interaction skills, validation skills, and with every single component, there are opportunities for the family members to interact and hopefully build social networks, because we know these families can get very isolated. and they desperately need support, more support and more sense of, I suppose, a community than they may have. So, and this is just the difference with Family Connections. It's run by family members, trained to deliver the program. Same whole content really. 2-hour sessions, up to 12 families. Seems a hell of a lot of families to me, but I'm used to seeing one-on-one, so maybe I'm a bit out of kilter with that. And the content of the program was developed with family members and with people with BPD. So I think that's highly significant. Again, 6 modules, practice exercises. I suspect that practice exercises are crucial. You know, how do you validate someone? How do you go about it? Because it's not always straightforward. And all modules include the social network bit of it. The Family Connections modules are introduction, education, relationship mindfulness, family environment, and validation. I think it's very interesting that validation gets such a prominent position in this. I happen to think it's probably one of the most important things that any of these programs can do is help family members to validate. I remember seeing he was a senior physician, as I remember, and he rang me, this is years ago now, many years ago. He'd seen a paper, Savia and I wrote about depression in BPD. It was in the NJA many years ago, hence a physician might have been. Anyway, he read it. And he rang me and said, oh, I think that's my daughter. You know, I think she's got BPD. Can I come and see you? And he was scared stiff, I could tell, of being blamed or being criticised and all that. That wasn't my brief at all. But from what he told me, you know, I didn't see that with his daughter, but I thought it was very highly likely, 99.99%, that she did have BPD. And I just talked about validation, told him to buy Valerie Paul's books, said I'd be happy, his wife wouldn't come incidentally, but I said I'd be happy to see them again if they wished. And I don't know whether he came again, I can't remember, I don't think he did. But somehow or another he contacted me later. He said, yeah, he'd read the book, and it was a very odd way of talking to people, wasn't it? I thought, well, yeah, okay. I don't know what I said to that. But he said the interesting thing was that he'd responded by trying to talk to his daughter who moved interstate, I suspect, to have some distance. And he'd had a conversation with her on the phone. Do you know, it was the best conversation we've ever had. And I thought, well, you know, I hope you read more of the book. But it's interesting, isn't it? And because I think that book talks so much about validation. It's really, it's core, I think, and clearly very effective when people learn from it. Now, so that was an uncontrolled outcome study on the Family Connections DBT program run by family members. Uncontrolled, it meant it didn't have another program to compare it with. But nevertheless, you note significant decrease in burden, grief, and significant increase in mastery over the program. And a further decrease in burden over a 3-month follow-up. So that was very interesting. Those findings were replicated and, in a 2007 study, and grief decreased slightly more during follow-up, but mastery decreased. What do I say? Grief decreased slightly more during follow-up, but mastery declared. Oh my God, I better do that again, Rita. I don't know what I'm talking about there. It doesn't make any sense, does it? Mastery
I wonder if grief, sorry to interrupt, but I wonder if grief increased because of the realisation perhaps of the gravity of the disorder.
Yeah, yeah.
Whereas mastery increased because there was more control over it.
Yeah, and that's the point that you made that point so well, because that was what I was trying to say about psychoeducation, why I thought it could make things, the anxiety, much worse, because I think, gosh, this is really severe, family members recognising that. So, grief decreased slightly more during the follow-up.
Maybe you need to say increase.
Oh, I see, yes. It decreased slightly more over the course of the follow-up, but mastery decreased, whereas it increased in the first study, but it decreased during follow-up in one and the two studies. Does that follow here? Not said very succinctly, but that's the thing. And it's interesting, depression, objective burden, subjective burden showed no change. And of all the measures, burden is usually the one that changes least. Now that's the lovely study with the follow-up and comparison with optimised treatment as usual. Significant improvement on burden, grief, depression and mastery. Optimised failed to, I've said this, I don't have to do it here. Now this is a very brief intervention by Channon's group here in Melbourne. 3 sessions of psychoanalytic, developmentally tailored, so tailored to adolescent age group, and family and friends of youth with BPD. Significant decreases in subjective burden and increased knowledge are reported at the end of the intervention, but objective burden and distress remained unchanged. And what we don't know is what might have happened on follow-up. And this is the MBT program, again developed collaboratively with interested families and professionals. The pilot program delivered by 2 family members who also participated in designing the manual. I thought that was fantastic that they participated in the manual. And it was a 5-week program, that's what the families wanted. And the results were published in this year, actually. These are the components. What is BPD? Obviously. Mindfulness and mentalising. Mentalising, everyone knows what it means, I guess, but it's the capacity to reflect on the mind of self and or other, particularly in terms of behaviour. What's this behaviour mean? Why is this person saying this? Or why did that person do this? You know, in other words, reflective function was its original name, and the original term used for mindfulness. I think it's much better, because mentalisation is about the capacity to reflect. You know. So then they do mindfulness techniques to help people manage their emotional reactivity, and mentalising talk in the interpersonal process. In other words, reflecting on minds type talk. And the 3rd session involves role plays. Again, I think this is great. You see there are role plays here, and role plays in the family, or practice in the family connections program as well. This one, role plays based on problems being experienced. So here and now, what are your problems? What would you like to role play? Very down to earth, very practical. And mentalising and empathic validation. How do you get these family members to see things from another person's perspective? How do any of us begin to be able to see things from someone else's perspective? And problem solving and review, using mentalising to try and problem solve. So you see the difference. DBT, emotional regulation, distress regulation, empathy, validation. We're talking validation here too, but it's much more about focus on minds and less on, I don't know. I just think it's the MBT focus is always on what's going on in the person's mind rather than
Is that just for family members? That's not for the individual with BPD?
Yes, it's only family members, but if you're, most of those families would probably have had a family member go into MBT therapy, individual family MBT therapy. Yeah. But even so, even if the family member, it doesn't say in the paper whether the family member is in treatment. Oh, and the other thing I must say before I end, what we have no idea of if in any of these forms of family intervention is what impact do they have on the family member with BPD? Does it help the family member? Does it improve the functioning of the person or the level of depression or anxiety of the person with BPD? We would hope it did, but we don't know that. It's not been studied in research, and that's a real need. Okay, this is what the MBT program found. Now, their primary outcome measure was the number of adverse events involving the person with BPD that was reported by a family member. So, physical violence, violent arguments, threatening suicide, conflicts about self-harm behaviour, significant declines in the incidence during and immediately after the intervention, better family functioning, increased sense of empowerment and well-being, and significant feelings of family burden remain. There it is again, a significant sense of burden. Follow-up was limited to 3 weeks, as I said before, but improvements were maintained over that time. Okay, so what to make of all this? Psychoeducation alone has very marginal benefit in my view, and it may increase anxiety and distress because of the fact that people who may not have been confronted before with what a serious illness this is will have been confronted with that through the psychoanalytic. Skills training and practice about how to validate, about mindfulness, about emotional self-management appear to be much more effective for families than just psychoed. I'm not saying the psychoed isn't important, I just think it has to be part of a package and not on its own. The sense of burden is not always affected by these interventions, and we don't know which of the various skills taught are most effective. We don't know as yet, and that needs to be studied. And as I said, we don't know what is the impact on the family member with BPD. So, things we need to find out. Do peer-to-peer interventions work better than those that are professionally led for families? They might do, needs to be researched. Are the changes shown after family interventions of lasting duration? Well, we have one study that showed lasting duration, that was the Flynn study. But we need other studies, we need confirmation of that, and we need the MBT people to see how long their effects last, and so on and so on. And I've said that, what effect do these interventions have on the patient themselves? And is the length of intervention related to effectiveness? In other words, if you have a 5-week intervention like MBT, because that's what the families wanted, would that be more effective than a 12-week Hoffman and presenting? We don't know. We don't know any of these things. Now, without research on the outcome of these family interventions, we can't know if they've been effective or not. That's why we need a focus on research. And we won't know if a particular intervention is more effective than other interventions. They need to be studied against each other. The famous gold standard randomised controlled trial. And nor for which family problems particular interventions might work best. I mean, some people might do much better with a DBT type intervention than a mentalising intervention. I mean, the same as people with BPD, some do much better with DBT than they do with MBT. And without the research, we wouldn't know that psychoeducation can in fact add to a family's sense of burden and distress and anxiety. We wouldn't know that. The only way we know is through research. And we certainly can't know without adequate follow-up if any positive effect is lasting. And just questions for the BPD Foundation. What can be done to ensure that all families and carers who want help with their family member with BPD can get access to effective help? At the moment, I don't think there's nearly enough access. Is that right? And the other thing I thought of while I was doing this, exploring this research, is it possible that the development of videos showing effective validation and effective emotional regulation on the part of the family member and other needed skills would augment face-to-face family interventions? Because I think, a good video, say a validation video, and people can watch it and watch it and watch it. And because Rome wasn't built in a day, sometimes more practice is needed that might be available in one of these relatively brief interventions. So I think that's one thought. And those are references for anyone who wants to do some reading. Okay. And last but not least, I think, I hope you all agree, that I think this work with families is terribly important, because I think it can make I suspect it can make a huge difference to the outcome for the person with BPD. But we have to show that, we have to do the research. So thank you for listening, and I told you about the physician, the rheumatologist. Any questions? Things you would like to ask?
I was thinking about the psychoeducation component of speaking to families, and